So first of all, congratulations for an excellent talk, and you raised the bar. It's a pleasure seeing you doing procedures, and what I would say, what surgeons were doing, you are gradually taking it away from them. So there were two things which I thought that you said. One was that you said that even in an inflammatory stricture, you would do a balloon dilatation. So the general teaching has been that for an inflammatory stricture, one may avoid balloon dilatation. So would you like to talk about it, one? And second is that you showed stricturoplasty endoscopically. Stricturoplasty has been the domain of the surgeons. So if you could also give us a little bit, some few details about it.
Yes, in general, actually, inflammatory, thank you again, Vinay, and it's great to see you and online. So in general, both inflammatory stricture and fibrotic stricture all can be treated endoscopically, and sometimes we call it mixed stricture. That means it has an inflammatory component and fibrotic component. But there is it's all related to the definition of the stricture. So in our guideline, any stricture which is regardless of inflammation or not, if you prevent the traversable to the traverse to the scope or push the scope with the resistance, you can do the gentle dilatation. But the gentle dilatation, if the inflammatory structure is a lot of inflammation, but the scope still have a difficult to go through it, you can use a smaller size balloon such as 13, 14, 15. But it's like if the mixed structure, you can do a little bit larger balloon. But there's an important concept that is here. We are saying is according to the consensus guideline, if the inflammatory structure have an ulcer, especially the deep ulcer, we should avoid balloon dilatation. But those patients would be benefited for structurotomy, because the structurotomy, you can select an area without ulcer and cut. The concept of this endoscopic structuroplasty, the same thing as a surgical concept. Surgical concept, especially this Lazzi McLeod's HM structuroplasty. Basically, what they do, they cut the structure in the horizontal section and the stitch in the vertical section, vertical orientation. Now the endoscopic structuroplasty, same concept. You open the structure, put the clip as a spacer to keep the lumen open. So this is the official term. And as a manufacturer, is not all the structure, even fibrotic structure, can be done for the structuroplasty. Only those structures shorter than 2 centimeters, especially the side-to-side anastomosis and the ileocolonic anastomosis structure. This will be the patient has the benefit at the most. Then, for example, endorectal ring structure, you cannot do the endoscopic structuroplasty.
Okay, thank you.
Dr. Uday, what is the usage of small molecules from your side? How often use and Thank you. I think Thank you. I think the last question from a surgeon, and probably we'll close the session. I would like to thank both Dr. Bhushan and Uday for the excellent lecture and the interaction. I just hand over to the mic to the co-chair. He's a surgeon. Probably the last question, or maybe the question from Dr. Professor R.P. Shanmugam, the senior surgical gastroenterologist and transplant surgeon.
Thank you very much. I would like to ask Mr. Shen, you said there is a fistula treatment, ileocecal fistula. Ileocecal fistula, as I think it is a natural way of going through the same passage. Why should you treat it at all? If it is another organ, then you'll have to treat, but it's the same. Why should you treat?
Actually, it is a great question. In our experience, it used to be this is like if the ileocecal fistula, you leave it alone. And our experience found out is that when you treat the ileocecal stricture, so we have a criteria. The stricture should, the fistula should not be the 2 centimeters thick, and the 3 centimeters should be shorter than 3 centimeters. Then the action would be you basically cut the stricture ileocecal valve. Then basically widening an area by doing the stricturotomy as well as the fistulotomy. Then our experience suggests after the treatment, there's small bowel inflammation above that. So the terminal ileal disease inflammation, multiple patients, terminal ileal disease inflammation disappeared. So so if the patient, I can tell you in the future, if the patient has limited terminal ileal disease, only one dominant stricture in the ileocecal valve with like 20 centimeters disease, and then they have a fistula there. Great news for the patient. So you can treat the fistulotomy, combine it with the stricturotomy, and then basically you can cure the patient with Crohn's disease ones.
Thank you.
If you talk about if the fistula from the small bowel to like the sigmoid, then endoscopic therapy, try to split the carbon water and the suture device doesn't work. The only work for the perianal fistula with the fistulotomy and the ileocecal fistula. And they also prevent in the future that area can get access formation at the branch of the fistula.
Thank you very much, sir. Dr. Uday Kumar, thank you very much for enlightening all the gathering here with the management of refractory IBD. And Dr. Bhushan, you have practically covered what all the surgeons do it. So I thank you very much and for enlightening such a complicated endoscopic procedures.
Thank you both of you. I am looking forward to see you physically for the future meeting. Thank you.